So I have a feeling that in the next decade or so, we're finally going to see innovations in urodynamic techniques where things become less invasive or non-invasive and have the ability to duplicate real-life situations better than we can do it in the lab.
Hello and welcome to our Winnovations podcast. I'm your host, Dr. Kyle A. Richards, and we have a superb program planned for today. This is the first program of our second season, and we're thrilled to be back in the studio in the Department of Urology at the University of Wisconsin. For this season, we're bringing in guests from outside the department to provide unique perspectives and to highlight the collaborative efforts that are required to innovate. We also want to generate discussion within the broader urology community so that we can continue to work together to make innovative advancements in urologic care. My guests for today, Dr. Victor Nitti and Dr. Frank Lin. Dr. Vic Nitti is a professor of urology and OBGYN, chief of female pelvic medicine and reconstructive surgery, or FPMRS, at UCLA, where he's also the FPMRS fellowship director. Now, he spent the first part of his illustrious career at NYU, where he was vice chair before moving to UCLA. And he's really one of the premier thought leaders in urodynamic techniques, medical and surgical therapies for urinary incontinence, pelvic organ prolapse, female pelvic reconstructive surgery, and voiding dysfunction. Welcome to the program, Vic.
Thank you, Kyle. It's my pleasure to be here.
And we also have our very own Dr. Frank Lin, who actually was our inaugural guest on our very first podcast in season 1. It's great to have Dr. Lin back. He's assistant professor of urology here at the University of Wisconsin, where he joined faculty in 2020. After completing his fellowship with Dr. Nitti at UCLA, I do want to get his perspectives on what fellowship life was like at UCLA. So we'll get there in a second. But prior to that, he was urology resident at the University of Arizona. He also did his undergrad at Penn and then also received his master's degree in engineering biotechnology. So he is a techie after all. And it's really, truly amazing to have Dr. Nitti and our own rising star, Dr. Lin, in the studio to discuss the topic for today, which is what's hot and what's not in overactive bladder. Frank, welcome to the program as well.
Kyle, thank you for having me.
So I got to get to my first burning question for you, Frank. So what was it like with Dr. Nitti?
It was a great time at UCLA. Dr. Nitti was an incredible mentor. Really assembled a multidisciplinary team at UCLA where we got experience with the colorectal surgeons, the urologists, and the urogynecologists. I had an extremely fabulous 2 years of training there.
Nice. Excellent. I think the first area that I wanted to touch on, and maybe we could get Dr. Nitti's perspective since he was really intimately involved with it, but it's really the botulinum toxin story. I remember when I was a resident at Wake Forest, we would drive to the Salisbury, North Carolina VA, and it's about a 35-minute drive. And back in those days, we would put CDs in our car. You remember that, Frank? CDs?
Yeah, I still have a couple of those sitting around.
Still have a few. And the AUA put out a bunch of these. I don't know if it was from the core curriculum, but there was one that I'm sure Vic remembers. One of the CDs was Vic Nitti talking about overactive bladder. And I still remember to this day, and he was talking about Botox or botulinum toxin story. And I've been really enthralled and fascinated with it. And to have him on our program today to sort of get into some of the weeds on the story, I think is just amazing. So Vic, can you tell us a little bit about the story? Like, how did you get involved in the development of botulinum toxin for overactive bladder? How did you settle on a dose? What were some of the pitfalls? If you could share that with us, it's really fascinating in my mind.
Well, I'd love to. And, it's near and dear to my heart because it is, to this day, one of the funnest things I've done in my career. And it's always great when you can have a relationship with industry that is fruitful for all parties involved. And I think that's the way it was for me. So the original thought was to use onabotulinum toxin A for the treatment of neurogenic detrusor overactivity and neurogenic bladder. And that's based on some very small studies that were done in Switzerland in the late 1990s, early 2000s. And based on those studies, Brigitte Church was the principal investigator. Based on those studies, Allergan, the company at the time who made Botox, got together a group of us in London to discuss the development of Botox for neurogenic detrusor overactivity. And as we were sitting in the meeting, you could tell we were all looking at each other saying, well, this is great if we can use it for patients with neurogenic lower urinary tract dysfunction, but boy, there are millions of people with just regular old overactive bladder that don't respond to medications. Wouldn't it be great if we had an indication for that? So those of us that felt vocal about it spoke up about it, and it sparked the interest of the company, and actually very quickly thereafter led to the development of the phase 2 trials to try and figure out dosing, and then the phase 3 trials to really look extensively at safety and efficacy at the chosen dose. Now, Botox is really challenging because there's so many different aspects to it. First of all, how much do you use? How many units? How many injection sites do you make in the bladder? What concentration do you use? How dilute, et cetera. So there's many, many parameters. We knew that the injection template from those original studies in Switzerland was one that appeared to be safe. So we used that. And then we just looked at multiple doses in the phase 2 trial, starting at 50 units and going all the way up to 300 units in patients with just idiopathic, as we call it, or non-neurogenic overactive bladder. When that data came back and was analyzed, if you look at the efficacy, how well it works, and then the safety profile, trying to minimize patients who would have incomplete bladder emptying that might require that they catheterize, because that is a potential side effect of Botox. 100 units seemed to be the sweet spot. And I think that Allergan at the time was a little conservative because they didn't want to push the limit of efficacy at the risk of having negative safety results, particularly with respect to that incomplete bladder emptying. So the 100-unit dose was chosen, and as it turns out, that was certainly the right dose.
Moving to Frank here, now in 2023. So Botox has, I believe, been on the market for over a decade now for idiopathic overactive bladder, FDA approved. Where do you see Botox fitting into your practice in 2023 and beyond? Is it a big part of the practice? How do you counsel patients that maybe are good candidates for it, and how does it fit in?
Yeah, that's a great question. I use a lot of Botox for my patients with idiopathic overactive bladder. When I'm meeting a patient for the first time, I talk to them extensively about the overactive bladder treatment pathway. So they understand that, it starts with first-line therapies and it moves more aggressively to possibly Botox injections. And they're always pretty shocked when I mention that Botox is an option, and they want to know how it's done, whether or not it can be done in the operating room or in the clinic. And some of my patients have come to me previously, I had Botox done with an outside provider, but it only lasted 6 months. And the second injection maybe only lasted 3 months, and they seem to have this diminishing return. And I want to ask Dr. Nitti what his thoughts were on that. And, is it just the disease getting worse, or is it the patient building a tolerance to the injection therapies?
Well, I think my answer to that is yes. So I think there are several reasons why one can see effects wearing off. One is the disease is getting worse. The second is it just wasn't a great injection. All of us have situations where, for whatever reason, that injection that was done, whether it's 10 injections, 20 injections, it didn't go well on that particular day. The third thing is, can patients build up a tolerance? And I think some patients do build up a tolerance, although we really don't know if it's tolerance versus their underlying condition getting worse. But let's say there are some that develop a tolerance. We know some patients will develop antibodies to botulinum toxin. So perhaps that affects things, although in the clinical trials, the development of an antibody response didn't really seem to affect efficacy. But nevertheless, it's possible. So although The recommended dose in the patient with idiopathic overactive bladder is 100 units. We do know that some patients will respond better to higher doses. And we can, if we go back to that phase 2 trial that I was talking about, you will see that patients at 200 units and 300 units, so there are patients who clearly do better on those doses. So we're just in the process of analyzing our data of all the patients who we dose escalated. In other words, they started out at 100 units, but in a shared decision making, we decided to go up in dose. And we have a good number of those patients. And certainly a number of those patients can be salvaged by using a higher dose.
That's really interesting. And I think the way that botulinum toxin was developed for overactive bladder, to me, it's just a great story. And I think we can learn a lot from it. And I appreciate you sharing that with us, Vic. I wanted to switch gears a little bit and talk about urodynamics. Urodynamics is, I think, going back to when I trained with Gopal Bedlani at the time at Wake Forest, was my mentor in urodynamics and was a big believer in getting urodynamics on many patients. And talking to some of my colleagues like Frank, I think the utility maybe has changed over time. So Frank, how do you think urodynamics fits into practice in 2023 and beyond? And has that shifted in from your training to practice in your first few years out here at Wisconsin? How do you see that evolving?
Yeah, it's a good question about urodynamics and its utility. I use it probably more sparingly than in general. When I see some of these new patients for overactive bladder, I really try to take a really good history and work through the pathway. I try to be hesitant on doing urodynamics prior to third-line therapies. I really have to make that decision. I give it to the patients as an option on whether or not they want to have testing prior to a more invasive therapy. There's a certain patient population, certain patient personality out there that wants testing as opposed to just trying Botox or trying sacral neuromodulation for their symptomology empirically. And that's the patient population I try to focus on. I counsel them it's an invasive test and it may be non-diagnostic is the piece. It might not replicate their symptomology that they're coming to me to try and fix.
And then I've heard too. There's some novel technology with sort of ambulatory urodynamics. Dr. Nitti, any thoughts on that technology, and where are we at with sort of more ambulatory UDS?
Right. Well, when you think about it, urodynamics hasn't changed much in the last 5 decades. The machines may have gotten a little fancier, but it went from analog to digital, but it really hasn't changed much. And we really are limited in how well we can reproduce symptoms in the setting of the urodynamics lab. Sometimes we're great at it, and sometimes we're not so great at it. Some people have certain conditions, the high risk neurogenic lower urinary tract dysfunction patient, where we're probably going to get our answer from a standard urodynamics. But sometimes we just can't. And it's uncomfortable, it's a bit invasive, and it is not a natural setting. Ambulatory urodynamics, as it has existed in the past, wasn't a heck of a lot different. You had the same contraptions, but you just walked around with it. Now there are folks that are developing using other ways to try and assess bladder function and bladder outlet function without needing to be hooked up to a machine. So there are some products in development. For example, one is a small little curled catheter that's inserted into the bladder, and it sits in the bladder, and it will get all of the natural readings within the bladder. And then the patient can correlate that with, for example, a uroflow into a flow meter, where they can be assessed when they're up and about, moving around, at home, etc. So that's one product that is now being investigated to see how well does it correlate with what we know about urodynamics. And it may be that with these new technologies, they're great, but we may have to come up with new norms. There's other potential technologies. For example, one of my partners, Lynn Stothers, has done a lot of work with near-infrared spectroscopy. And these would be actually wearable devices where you can get information on bladder function, bladder filling from an external wearable device. And athletes use these devices to measure all kinds of parameters as they're exercising, et cetera. So something like that would be great because it's non-invasive. So I have a feeling that in the next decade or so, we're finally going to see innovations in urodynamic techniques where things become less invasive or non-invasive and have the ability to duplicate real life situations better than we can do it in the lab. And of course, that will lead again to we may have to redefine norms. But I think in many patients, it will be an advantage over what we have now.
That would be huge. Yeah, it's interesting that not much has changed in urodynamics over the pretty much your career. Frank, do you think it would be something that, getting more data, right? You get more data, you have to sort of figure out what to do with it. Do you think more data would be useful in helping to sort through some of these complex patients?
I think the ambulatory urodynamics testing technologies that are in development have the potential of giving us more accurate data. And I think that's really where it comes down to. You could run a study 10 times and never really replicate symptoms or maybe get some artifact, and that doesn't really help the patient at the end of the day.
Well said. I want to move on now to medical therapy, right? So medical therapy has really been a mainstay of treatment for overactive bladder for decades, but there's been some recent publicity and data that has made an emphasis on some of the long-term risk, specifically regarding anticholinergic medications, risk of cognitive decline. I'll start with Dr. Lin here. So do you think these risks are legitimate? Is there issues with the data, confounding? Are they cause and effect? What do you think about all this data that's come out?
Yeah, great question about anticholinergics and overactive bladder and what the risk is for cognitive side effects. A lot of big retrospective studies that have shown some association, but absolutely, no cause, no smoking gun causation. I think that's the key of it. You do always hear the occasion, the patients that come in, they're frail. And gosh, you start them on anticholinergic, and the next thing you hear is, they don't feel quite the same, or maybe their family members have noticed that they're not quite as awake, or they're confused, or they have a fall in the middle of the night, and you got to stop that anticholinergic immediately and try some different therapy.
What are your thoughts, Dr. Nitti, regarding this? I don't know if it's a controversy, but it's certainly out there, and I think there's more awareness, it seems like, regarding the risks of anticholinergics.
Well, there's definitely more awareness, and I do think it's real. But let's break this down practically. So for years, anticholinergics were the only medications that we had to treat overactive bladder, to treat even neurogenic detrusor overactivity. And attempts were made to make a better anticholinergic, an anticholinergic that would have less side effects, dry mouth and constipation being the main ones. But no anticholinergic was so urinary tract specific that it eliminated those side effects. The same can be said for potential cognitive dysfunction. Now, the studies that have been done, they've been done on overactive bladder anticholinergics, but they're more, it shows an association, but the studies have not been done to show a definitive cause and effect. But there's a definite association of cognitive dysfunction and dementia in patients who have been put on an anticholinergic versus those who have not. So I would say, bottom line, yes, there's some risk. At the end of the day, you could say, why ever use an anticholinergic in overactive bladder? We have another class of medications, beta-3 agonists, that don't give dry mouth, don't give constipation, and seem to work as well as anticholinergics. And I think that the main reason that anticholinergics are still used today, at least in idiopathic overactive bladder is because of insurance coverage issues. The beta-3 agonists are exclusively branded. There's no generic at this time. So third-party payers don't want to pay for the more expensive medication, and many times you are forced to use an anticholinergic first, or use 2 or even 3. So that's the main issue now. Short-term use of anticholinergics is probably just fine, certainly if it's less than 4 weeks. Now, a place where I find anticholinergics to be very practical is in addition to a beta-3 agonist. So I have a patient who has an inadequate response to a beta-3, sometimes adding an anticholinergic, which works by a totally different mechanism of action, will give them substantial relief, but they are told about the potential side effects. The neurogenic population is a little more challenging because we still don't know really how useful beta-3 agonists are in the high-risk neurogenic patient, the patient who's at risk for upper tract decompensation because of high bladder pressures, where we know that anticholinergics work to lower bladder pressures. But another argument you can make is, why have these patients suffer the side effects of anticholinergics? Just go right to botulinum toxin. I think anticholinergics over the next decade will be used less and less and take more of an ancillary role, at least in the treatment of idiopathic overactive bladder. But we'll just have to wait and see what happens.
And Frank, are you having issues with the cost of the beta-3 agonist as well that sometimes prevents you from prescribing that for certain folks?
Yeah, absolutely I am. Similar to what Dr. Nitti's experience is with patients trying beta-3 agonist. Insurance coverage is highly variable on those drugs. There are 2. I always tried Myrbetriq as my first beta-3, and for a certain patient, a $5 medication is what they're expecting. And if it's $50, then that might be too expensive for a particular price point, especially if they have fixed income. And certainly, I've definitely had patients come back to me saying, hey, this medication was going to cost $500 a month. That's not affordable. And that's a huge barrier to getting them treatment.
Yeah, definitely something that we'll have to keep an eye on. And as these drugs go generic, I think that'll be a huge help in controlling cost. I wanted to get into, there's really I was just at the North Central section meeting in Scottsdale and actually was enjoying the FPMRS session. I think Frank was surprised to see me there, but I was taking notes so I could build up my knowledge base. But I was really fascinated by some of the exciting treatments that are on the horizon for overactive bladder. So I want to go through some of these. I saw that there are some new approaches to posterior tibial nerve stimulation. And Frank was actually cluing me into this. There's an approach where it's done above the fascia or below the fascia. So maybe, Frank, we can throw this one to you. Maybe explain what that means and what are your thoughts on this sort of new approach to posterior tibial nerve stimulation?
Yeah, posterior tibial nerve stimulation, or sometimes called percutaneous tibial nerve stimulation, or PTNS, is a form of neuromodulation. Typically, it's in the third line therapies for overactive bladder, and they're typically office-based procedures where a patient comes in once a week for 30 minutes of treatment for a 12-week period as an initial sort of initiation therapy to see if this helps them with their overactive bladder symptoms. There are certain devices on the market or coming to market as well that are implantable devices in the ankle area that are available out there on the market. And they sort of are classified into above the fascia or below the fascia. I don't personally do any of these therapies at this time.
Have you dabbled in it at all, Dr. Nitti?
Yes, and the issue has been reimbursement and implantation codes, and those are now beginning to become better defined. I'm not sure where implantable tibial nerve stimulation is ultimately going to end up. I was very excited about it when the technology was sort of first proposed. And I thought, gosh, this will take over for sacral neuromodulation. When you look at some of the studies that have been done on some of the devices, it almost looks like the results are too good to be true. So I'm very curious to see how these perform in the real world. And what I hope we'll see is we'll see patients who are particularly well suited for that type of therapy versus patients who are particularly well suited for standard sacral neuromodulation. They may be a very different group of people. We just really have to wait and see. And you think, well, some people will love this idea of having something in their ankle, but there are some people that may not want a little scar on their lower leg. It may leave a little scar. Certainly, if you have a patient that has ankle edema, they're not great candidates for any of the therapies. So there's several different ways that this can be performed, but I am very curious to see how it behaves in a real world, non-clinical trial setting. If we go back and look at lessons learned from sacral neuromodulation, so sacral neuromodulation, the original studies that were done in the late 1990s, it looked pretty darn good. Its adoption and success rates in practice was abysmal until we finally figured out, thanks to people like Steve Siegel, we have to optimize this technique and really make it work properly. I don't know if there will be an aspect of that to implantable tibial nerve stimulation. I don't know if there's a certain patient population that will do better with implantable tibial stimulation. So I think we have a lot to learn and a lot more to do in that area before it finds its ultimate place moving forward.
Yeah, well said. So maybe not quite ready for prime time yet on the PTNS.
Or it gets introduced into prime time and we learn from prime time use exactly where it's going to fall. I suspect that's what's going to happen because for many patients, it does seem very appealing. I just want to see how it works in the real world in very specific populations.
Yeah, I think that's fair. And you brought up sacral neuromodulation. There's this new, the Medtronic versus Axonic debates or device. Where are we with that, Frank? Any thoughts?
Yeah, Medtronic has been on the market for many years, and they're your traditional company for sacral neuromodulation device. Axonics is a newer player to the market, and they've partnered with Bulkamid for stress urinary incontinence. At the University of Wisconsin-Madison, we use Medtronic devices mostly from a company coverage perspective more than anything.
And have you shifted gears at all, Vic, or dipped your toes in the Axonics water?
I have implanted some of their devices. I think that the key to sacral neuromodulation is the patient selection and the placement of the lead. And whether it's a Axonics lead connected to an Axonics IPG or a Medtronics lead connected to a Medtronics IPG, I think that lead placement is the most important thing. Now, each company will argue that there are various attributes to their product that may make it better. But I think what's made sacral neuromodulation better in the last decade is very strict attention to detail to making sure that the lead is placed in an optimal place and that the best patient for sacral neuromodulation is selected.
Is there any benefit to the Axonics over Medtronic?
Well, both companies have both permanent fixed life batteries and rechargeable batteries. Both companies now have a longer life fixed life battery. If you speak to the companies, they would tell you ours is better because of this or theirs is worse because of this. I am not convinced that any of those attributes of the device make a huge difference to my individual patient.
That's fair. Frank, what about eCoin? What's the eCoin? I saw that on the menu.
Yeah, eCoin's one of those implantable PTNS items. So I don't know if Dr. Nitti has any experience doing it.
Yeah, well, an e-coin, basically it looks like a nickel, and it is fairly easy to implant, and it sits on top of the tibial nerve, on top of the fascia. So the implantation zone is a safe zone. I think the key thing when you place an e-coin is it's more of a plastic surgical procedure to make sure that you get proper wound closure and avoid infection. We have classically operated in areas that are very forgiving, rich blood supply, the perineum, the vagina, etc. But when you are in the ankle, if you make a mistake in wound closure, you can get an infection or a wound breakdown. It's a totally different ballgame. So with an e-coin, you have to really have meticulous implantation technique, and it's really all about the wound closure more than anything. The device then is programmed to stimulate, I believe, 4 times a week for around 30 minutes. And, the other question I have with some of these devices is that stimulation menu optimal for some patients, or do some patients really require more? You have another device, the Blue Wind device, which is a lead that's implanted below the fascia, which it just sits under the skin, and then it's connected to an external stimulator. The disadvantage is you have to have this external stimulator. The advantage is the patient could use it as much as they want. So that's where these technologies differ. And it may be, depending on the patient, one is best or the other is best. The big question is going to be, can we figure that out before we implant the device?
That's great. Now, Vic, are there any other new technologies on the horizon in trial or coming to market that you're most excited about?
I mean, there are other neuromodulation devices available, neuromodulation devices where stimulation will come externally instead of the patient, sacral neuromodulation, where it could come externally rather than have an implantable battery. Is that, I would imagine, assuming it works well, that would offer some advantages to some patients. It might be a disadvantage to other patients. I expect that there will be other forms of botulinum toxins or delivery of botulinum toxin. These are theoretical things. There is a gene therapy that's out there that's, I believe, moving into the next stage of their phase 3 trial, a gene therapy that affects potassium channels. So, it's an injectable gene therapy. Is that something that's going to potentially be a good thing for certain patients? Maybe. We'll have to wait and see.
Yeah, lots of exciting stuff on the horizon, that's for sure. And Vic, it's been great having this discussion. I've certainly learned a lot from the both of you. As a urologic oncologist, I always enjoy talking to my urogyn colleagues, and we are running out of time. So any last words for us, Dr. Lin or Dr. Nitti?
I just want to say thanks for having me. It's been a pleasure to do this with you and to be able to work with Frank again. We miss him at UCLA, but we're glad he's found a home where he's happy and thriving and making a difference in patients' lives in Wisconsin.
Thank you, Kyle, for having us. It's been a great talk and a great way to kick off season 2 of Winnovations.
Excellent. Well, thanks so much. I really appreciate having both of you on the program, and we'll be signing off here. Have a good rest of your day, and thanks for tuning in. So long.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.